entitled Additional Risk Variant in GDF15 and a Stronger Maternal Genetic Influence Linked to Hyperemesis Gravidarum.
Thank you for having me. So the majority of women have some nausea and vomiting of pregnancy, and even animals can have nausea of pregnancy. For example, this gorilla, Kayala, was in the news recently for not even being able to eat its favorite cookies. But hyperemesis is at the very severe end of the clinical spectrum, the worst 2%, generally defined by having at least a 5% weight loss, electrolyte imbalance, there can be ketones in the urine, and they can require medication, IV fluids, and hospitalization. There's significant maternal morbidity and mortality associated with HG. 26% lose more than 15% of their weight, 22% have symptoms until term, 18% have full criteria post-traumatic stress disorder following HG pregnancies because of the severity, and over a third decide not to have no more children. This is also due to the severity and the high recurrence risk. Reports of Wernicke's encephalopathy are on the rise, and women can have detached retinas, pneumothorax, esophageal tears, rib fractures, and blown eardrums from the violence of the vomiting. They can also have liver, kidney, and gallbladder dysfunction, and there have been maternal deaths secondary to HG in this century in the US and the United Kingdom. There's also significant fetal morbidity and mortality, an increased risk of preterm birth, small for gestational age, low birth weight, smaller head circumference, increased risk of neurodevelopmental delay, including autism spectrum disorder, reduced insulin sensitivity, increased cortisol, and increased blood pressure, and vitamin K deficient dysmorphology proves that with HG, the baby is not always getting everything it needs from the mother. So why use a genetic approach to find the cause? Decades of research have failed to find the cause using any other method. It's commonly assumed to be HCG and or psychological with little scientific evidence to support it. Heritability estimates for the presence of nausea, vomiting, and pregnancy are high, 73%, and over 50% of variation in duration and severity of MVP is heritable. There's familial aggregation of HG with a 17-fold increased risk of having it if your sister has it. And a GWAS approach to the etiology is unbiased with respect to which genes are involved. All genes will be scanned. So we also partnered with the personal genetics company 23andMe and scanned over 15 million variants in over 17,000 women, and we found no evidence to support the HCG gene nor its receptor. What we did find when we compared the ends of the clinical spectrum, women with HG to women with no nausea and vomiting, was that the placenta and appetite hormone, GDF15, was significantly associated with HG with a p-value of 10 to the minus 15. When we did our second scan, we added the people in the middle plus the severe ends of the clinical spectrum, and again, GDF15 was the top hit with a p-value of 10 to the minus 41, very significantly associated not just with HG, but with every level of nausea, vomiting, and pregnancy. In addition, the receptor for GDF15, GFRAL, also showed up in the second scan. Then we did a conditional analysis, which is basically where you take away the linked SNPs with the top hit, and then you see if there's any underlying SNPs, and we did find a second hit that is not linked with the first one in the conditional analysis in GDF15. We did a replication study, and we used a TACMAN genotyping platform on the 3 unlinked variants in the GDF15 pathway, and all 3 variants, 2 in GDF15 and 1 in its receptor, were all significantly associated with Hyperemesis Gravidarum. And this was in clinically defined cases of Hyperemesis Gravidarum who had IV fluid treatment compared to controls with normal nausea and vomiting or no nausea. Then we compared 136 women with no nausea and vomiting to 102 women with HG requiring TPN, the very ends of the clinical spectrum, carrying either this genotype or this genotype in GDF15, the two unlinked variants that we found, and we found that women with either this variant or this variant were 12 times more likely to have no nausea and vomiting than to have HG requiring TPN, suggesting these are protective variants from getting hyperemesis. So what is GDF15? It was formerly called the macrophage inhibitory cytokine 1. It's expressed at the highest levels in the placenta and activates the vomiting center of the brain. It's found in maternal serum and increases significantly in the first trimester. It's a predictor of miscarriage and downregulated in serum prior to miscarriage. Increased serum levels of GDF15 are associated with HG hospitalization, antiemetic use, and second trimester vomiting. It's a regulator of weight and appetite via activation of neurons in the hypothalamus and area postrema. Abnormal overproduction of GDF15 in cancer drives cancer cachexia, so it also causes cachexia, which is a disease very similar to hyperemesis, muscle wasting and weight loss. And it also recently was shown to be upregulated in chemotherapy-induced nausea. Inhibition of GDF15 restores appetite and weight gain in animal models. The receptor for GDF15 and GDF15 itself promote weight loss, pica, vomiting in animal models, likely through a different mechanism than the 5-HT3 receptor. And GDF15 is upregulated in response to nutrient deficiencies, long-term fasting, hyperthyroidism, and infection independent of being pregnant. So I suggest the possible model for the role of GDF15 in HG pregnancies is this. If you have a variant in GDF15 that makes you slightly increase your levels of GDF15 produced by the placenta, that's going to travel to the bloodstream, to your brainstem, and you're going to get more activation through GFRAL, the receptor. That's going to cause appetite loss, taste aversion, nausea, and vomiting. And that can lead to nutrient deprivation, long-term fasting, hypothyroidism possibly potassium depletion. You may have an H. pylori infection, and all these things, independent of being pregnant, cause an increase in GDF15. So then you get this cyclical downward spiral caused by the increase in GDF15, increasing and increasing more until you get Hyperemesis gravidarum. So we've shown that the maternal genes are involved. What about the father's genes? So we did a study where we asked 793 women with HG and 572 women with none or normal nausea to report on the NVP levels of their sisters and sisters-in-law. And comparing the NVP levels of sisters of 793 women with HG requiring IV fluids to NVP levels of sisters-in-law of women also with HG, we found that women with HG are almost 6 times as likely to report their sister also had HG than their sister-in-law. This suggests the maternal genetic component plays a greater role in the susceptibility to HG than a paternal genetic component that may be expressed and passed on in the fetus or placenta. Then we did the opposite thing. We compared the NVP levels of sisters of 572 women with normal or no nausea and vomiting to the NVP levels of their sisters-in-law, and women with normal or no MVP were almost twice as likely to report their sister had little or no MVP than their sister-in-law. So this suggests at the other end of the spectrum, the maternal genetic component plays a greater role in the susceptibility to low or no MVP than a paternal genetic component that may be passed on to the fetus or placenta. So in summary, we found 2 unlinked variants in GDF15 and 1 in its receptor, all associated with HG. And maternal genes appear to play a more significant role than paternal DNA in contributing to the severity of NVP. In our other studies and other people's studies, GDF15 variant has been associated with recurrence risk defined by more than 5% weight loss. GDF15 variants segregate with disease in HG families. Preliminary evidence suggests the GDF15 hormone levels may be increased in HG pregnancies, but more work must be done in larger cohorts at different gestational ages. Recombinant GDF15 activates the brainstem and causes nausea and vomiting in some animal models. And GDF15 GFRAL therapeutics developed for cachexia and chemotherapy-induced nausea are very promising. Other factors that increase GDF15 levels in addition to genetics may explain HG, such as nutrient deficiencies, and no variants in HCG nor its receptor are associated with HG. So in conclusion, there's a larger body of evidence to support a role for GDF15 in HG than for any other theory at this time. So what's next? Are the findings replicated in other populations? Can we predict risk based on the genetics? What else contributes to HG, such as rare variants or fetal DNA? Can serum levels of GDF15 be used to predict, diagnose, and eventually treat HG? And can a GDF15 or GFRAL inhibitor work as a drug for HG? That is the ultimate question. And this paper just came out a few weeks ago in Cell Metabolism, proving that GDF15 doesn't just cause nausea, but also causes vomiting. And they want to call GDF15 imitaversin. And I think this paper and other papers about GDF15 that have come out recently in top journals are going to inspire pharmaceutical companies to target this pathway, and that we will have a drug soon that hopefully will be safe in pregnancy and effectively treat HG. I'd like to acknowledge Dr. Mullen from USC and Kimber McGibbon from the Her Foundation for their support with this study, and the others that have also helped with the study. Thank you.
So this abstract is open for questions, and while hopefully people come up, Dr. Fejzo, I think you are to be congratulated on tackling what is really a very difficult and challenging problem for obstetricians and for the patients as well. Can you comment on whether there are potential racial differences or implications for your findings?
That's a good question, and unfortunately I don't have the answer to that, because when we let everybody of any race participate in our study, it turned out that over 90% were white of European descent, and 23andMe limits their study to people that are white and of European descent. But I hope that other people in other countries will start to do follow-up studies on this so that we can figure that out. I assume it will be the same.
Thank you. Please go ahead.
Alessandro Ghidini, very interesting because it opens, gives some explanations as to why these women develop this problem. Now, we see differences within the same patient with different pregnancies in severity of the condition. So would you expect an autosomal dominant or X-linked actually pattern of inheritance? How do you?
Yeah, that's a very good question. And one of the theories that I have is that it may be that if the fetus inherits the maternal allele, and that the maternal allele is expressed in the fetus as well as in the maternal or the fetal component of the placenta as well as the maternal component, then you would have even more GDF15. Whereas if the mother also carries alleles that make their nausea less, and they inherit that, then that may explain why they may have it in one pregnancy or not. We've seen about an 80% recurrence risk in our studies.
Great. Catalin.
Catalin from Chicago. Great presentation. Somehow related with what Alessandro was asking. Why do you think, from this perspective, hyperemesis is getting better in the second and third trimester?
That's also a really good question and perplexing, because GDF15 does seem to go up and up in pregnancy. So I would guess that it has to do with the receptor. This is just theoretical at this point, but there's probably a limited number of receptors there, so that you get to a certain threshold and then you can't get any more after that, any more stimulation. But
because you have a very high number of patients with Hyperemesis Gravidarum, and probably analyzing the data from the perspective of improvement rather than categorical yes/no Hyperemesis Gravidarum might provide some answers to that question.
yeah, that's true. There's another variant that I didn't talk about because I wanted to just put most of the focus on the top hit, which was GDF15, but we did do a study with the second locus, which is IGF-BP7, and we did find that with that locus, there was an association with having nausea and vomiting going into the second and third trimester. So that variant and that gene may control how long it lasts.
Yeah, Meredith.
Meredith Rochelle from Lehigh Valley. All of your data on pregnancy outcome, that was all survey data, or did you validate any of that with medical records, et cetera?
The pregnancy outcome data in the early slides on the background.
When you determined how much hyperemesis the patient had and what category of hyperemesis, that was based on what patients reported?
Oh, yeah, so patients had to have IV fluid treatment. That was our clinical criteria, not for the 23andMe data, but for the validation data. And so all those women, we requested medical records from all of them of their IV fluid treatment.
Okay, thank you.
Great, thank you very much.